A very good afternoon to everyone. On behalf of Walters Kluwer, a warm welcome to our speakers and attendees on this nursing webinar under our new Nursing Edge series. Our topic today for this webinar is evidence-based guidelines in critical care nursing. And we have two speakers today. Our first speaker today is Dr. S. Madhavi, who's the principal of KMCH College of Nursing, Coimbatore. She has presented, if I talk something about Dr. Madhavi, she has presented various papers in nursing subjects and topics. She is also an advisor to nursing services, Koi Medical Center and Hospital, and involved in the NABH accreditation process. She is also recognized PhD guide for the TNDR MGR Medical University, Chennai. She was also an executive director, editor of the TN Nursing Council Journal of Medical Surgical Nursing. She is also in the South Asian Advisory Panel member of the Lippincott William and Wilkins Publishers. She is a Senate member of the DR MGR Medical University, Chennai from 2004. She was also a member Board of Studies in Nursing of the MGR Medical University, Chennai from 2013 to 2015. Our second speaker today is Mr. Alan Finn, who is a senior editor consultant for Ovid and Lippincott based in Sydney, Australia. He has been creating and presenting educational material for the last 20 years. Ovid provides access to the wide variety of content, including evidence-based books, journals, and databases for nurses and allied health professionals. And today, he will present the JBI evidence-based practice database in the last 15 minutes. So now I request, and also we will be taking all questions at the end of the webinar. And also you post all your questions in the Q&A panel of this event. We'll try to address the maximum questions possible. We will also provide the feedback link in the webinar chat where you can give your feedback on the session. Now we begin our session, and I request Dr. Madhavi to please share her screen. Dr. Madhavi, ma'am, please share your screen.
Good evening to one and all. It gives me immense pleasure to meeting you all on this good evening to speak on very vital topic, evidence-based guidelines in critical care nursing. Earlier, we have heard a lot about doing things on trial and error basis or intuitively we have been doing. So evidence-based practice has become a buzzword nowadays, and let us see about evidence-based practice in this 1 hour time. If there is any questions, you please post it in the chat box. I'll be answering it. And now I would like to share my content. Is my slide visible and
yes,
audible?
Yes, yeah, ma'am. Very much. Thank you, ma'am.
Thank you. So I carry a lot of good wishes and greetings from the management of KMCH College of Nursing, Coimbatore, which is a premier institution where I am working as a principal, and I'm privileged to meet you again in this webinar. So this will be, I'll be covering on what is evidence-based nursing and quality care, why evidence-based guidelines, how to assess evidence, integrating in EBP in critical care, EBP guidelines in critical care nursing, and barriers and overcoming that. So as you all know, I would like to give a big salute to our pioneer, the Florence Nightingale. You all must be wondering, nearly 200 years. Now we are in the 200 years of our birth centenary. So she, as a pioneer, has been always interested in creating evidences. During the Crimean War, she was the one who created evidence, statistically prove what has been causing the illness among the soldiers, and I think she is a pioneer. So of late in 2000, nearly 2000 like that, when the Institute of Medicine has given out the paper on to erase human. That is the time we have been started talking about evidence-based practice. But she is the one who talked about, and as her quote says, the very first requirement in a hospital is that it should do the sick no harm. So that's, she is always interested to see that the patient gets the best, and she's the one who given out the world the very idea of critical care nursing. The very sick people she kept closer to the nursing station, and the ones who need lesser supervision, she kept it away. So that is the concept. So continuous monitoring, surveillance, and all that was a contribution to the world, and it is befitting to give her a big salute and go into the topic of today's presentation, evidence-based critical care nursing. So when you talk about the care that is time-bound, safe, effective, efficient, equitable, and patient-centered care is defined as the quality care as per the Institute of Medicine. So evidence-based care is the key to achieve quality care. So when you look into the history of evidence-based medicine, evidence-based nursing, it's just 20 years, scrolling back to 2 decades, I believe, when the Institute of Medicine released it, and then onwards, evidence-based medicine came first and followed by evidence-based pharmacy, and slowly the nursing also embraced evidence-based care, and so the curriculum includes now evidence-based care, and it is now a mandate. If you want to give a quality care, you need to be evidence-based. So quality and evidence-based care are inseparable. It's a means to achieve the end of quality care. So what is evidence-based practice? It's a problem-solving approach by which the healthcare providers make a clinical decision using the best available scientific evidence, one's own clinical experience, and patient preferences in the context of available resources. So from this definition, it is very clear that evidence-based practice is a problem-solving approach, and it is not equal to research application, because research application, all research conducted are not applicable, or maybe locally it is not applicable. For example, when I was doing my PhD research on cardiac surgical patients, I was looking for a questionnaire, and that was trying to give quality of life questionnaire for cardiac surgical patients, where lawn mowing was there, lawn mowing and driving. So whereas it is not applicable to our situation. Okay, so that's another one important thing is like best possible evidence. So it is not just scientific evidence, it is the best possible evidence. So it is trustworthy, and it is not just application of it, or it is not just synthesizing it. It's not just a systematic review. We use systematic review very much, but it is not equivalent to evidence-based practice. Here we have this space for our clinical experience as well as the patient preference, and based on that, when you take decisions for the patient care, it is called evidence-based practice. So this picture could very clearly depict the best evidences. Always, whenever you say science, it need to be having an empirical evidence. So scientific evidence is very, very essential. Then clinical expertise and patient preferences are key players to decide on how we are going to go about the patient care. So evidence-based guidelines, there are, what are these evidence-based guidelines? Evidence-based clinical practice guidelines as a body of evidence into a usable form. It's unlike systematic reviews, but we use systematic reviews to give, based on the systematic review, specific recommendations for evidence-based practice are given. So it is not equal to systematic review or synthesis. So guideline development typically involves the consensus of a group of researchers, experts, and clinicians. It is not just one person saying something. It's a group of authenticated experts. Say, for example, critical care medicine, Society of Critical Care Medicine, they have given out guidelines for various things. Then Center for Disease Control has given out the guidelines or the bundles for prevention of VAP, prevention of 40, prevention of SSI, so many things. So what is this bundles then? Evidence-based bundles are, it's a group of bundled interventions, maybe 3 or 5 or something, which has some strong scientific evidence in support of those interventions so that it can give out the desired outcomes. So again, evidence-based guidelines are very broad, and the institutions, based on the local factor, the group of people whom it is decided, it all taken into consideration. So there is some amount of this, all recommendations, and it is the institutions who can adopt and make a modification of it and then apply it to see whether there is any improvement, desired improvement or not, like that. So implementation or adaptation of clinical practice guideline is often an ideal focus for an organizational EBP project. What are the key competencies for evidence-based practice? The competency to identify areas that require improvement, very, very essential. We should know where we are lacking. That is the first insight that a nurse is needing to go ahead with evidence-based practice. If you want to adhere, you should know where we are, what are our pitfall, what are our strength, what are our weakness, what is the in terms of applicability, all that she need to know. She need to describe the lack of evidence or weakness in her routine task, and identification of research evidences. So you need to, there are, and in the information era, if you touch Google group, you get thousands and thousands of research reports, some of which are not at all plagiarized, some are not very weak, and some are really worth it so that it can be applied. So you as a nurse need to be smart to know which is applicable, which the critical appraisal of research evidence as a very, very essential component or key competency for EBP. So then you have to identify the gaps in the evidence in routine nursing and in the standard one, then you need to create a pragmatic solution to the current health problem, applying the reliable evidence, and you need to integrate it. And as a leader, you need to, when you want to be an evidence-based practitioner, you need to take the group along with you. So you need to have communication skills, and you need to be capable of convincing people, and you need to have a lot of insight to do that. That's all other competencies essential for a nurse to go ahead with EBP. So combining current literature with site-specific evidence provide a foundation for action towards better patient care. Because as I gave you some examples, some difference are there. Clinical presentations or gender-wise presentations vary, gender-wise efficacy of nursing intervention vary, and the applicability in different ethnic groups. For example, even certain aspects of the cultural practices vary. So there is a difference in the outcome also. So you have to combine the current literature with site-specific evidences. That is very essential. Then determining the level of evidence is key component in appraising evidence. Appraising the quality is essential to ensure that the evidence is you're not just closing your eyes and somebody it is published, so it has to be followed. Nothing like that. You need to critically evaluate whether the results are applicable, whether this intervention is a rigorous one, whether there is any logic behind there, it is reliable, valid, and appropriate for inclusion into practice in your clinical scenario. So that is very, very essential. So to do that, there are a variety of rapid critical appraisal checklists are available, and Johanna Briggs Institute and they are giving critical appraisal tools. See, when you read the article, you have to evaluate its validity and reliability. So how do you do that? So these websites give you very beautiful tools. Say, for example, the evaluation or rigor of a RCT cannot be the same done with the correlation cohort study. So you need to have a different idea things, and these appraisal tools are available. You can actually, I thought I will give you one or two glimpse of those tools, but I could not because so much is there. So you can visit these websites to get the critical appraisal tools, and you can start doing those practice. So what are the levels of evidence? When do you say the American Association of Critical Care Nurses gives the evidence levels as A, B, C, D, E, whereas Society of Critical Care Medicine gives like a level 1, level 2, level 3, level 4, level 5, like that. So what is the difference between these things? What does level A signifies? It's so when the evidences are arising from the meta-analysis of quantitative studies or meta-synthesis of qualitative studies, that results shows consistently supporting a specific intervention. For example, ventilator associated pneumonia VAP, in that avoid intubation and extubation and re-intubation need to be avoided because the chance of VAP is more. So this is based on consistently the meta-analysis done by various authors have shown that it is evident. So it is a very strongest and it is a top of the evidence. And level B, well-designed controlled studies with highly rigorous, where the extraneous variables or confounders are adequately controlled with specific relevance. So is supporting a particular intervention. That is a level B. Then level C is a qualitative studies, descriptive studies, systematic reviews, which are having some inconsistencies. So some systematic reviews in favor, or some studies or cohort studies or descriptive studies supporting or no inconsistency. So that is a level C. Level D is peer-reviewed professional and in support with the support of 1 or 2 studies. And level E is multiple case reports, but theory-based expert opinion, and without clinical studies, scientific evidence are less. So that is level E. Then level M is manufacturer's recommendation. Say, for example, some issues related to ECMO, because in the critical care unit, it's a very specific, and the current critical care scenario is vastly changed with the in the clinical dimensions as well as in the technological aspects. What were not seen earlier, as a student in the 80s, I have not seen ECMO at all. And in the 90s, I saw IABP. So there is so many difference, and each one has a specific implications. And all these technological device has its own pros and cons, and they are giving recommendation. You do this, you do that, like that. So based on that, when it is called, it is level. Yeah. So this is another, commonly used, another level of evidence pyramid, where the systematic reviews, quality. So the filtered, the top three has highly valid, highly reliable, with the filtered, the inconsistencies are not there. Say, for example, the systematic reviews using the Prisma framework, it gives very clear evidence. Most of the studies supporting a particular intervention and without flaws or bias. So those things are, so you can see the quality of evidence increases towards the apex of the pyramid. So the critically appraised evidence synthesis and critically appraised individual articles, individual RCTs. So more than single RCTs or single site RCTs, a few RCTs. So when you are based on those recommendations, if it is done, it is the second level only. Because why we are thinking about? Because when you look into the research evidence that emanates on certain particular topics, you can see n number of researches done. Whereas on some, and there may be so many inapplicable studies, interventions, designs, and so forth. And in certain areas, you don't have no much of research. There is a depth of research, but there are only but very valid and one or two studies done at a single site. It can be level 2. Then that is the level of evidence or filtered evidence. And then randomized control trial with flaws and biases and cohort studies, this with unfiltered informations, with the with the weaknesses in the study designs, in the methodology, and in the analysis. Even the analysis need to be appropriate. You cannot even the ambiguity can be even in the relationship that hypothetically when you are relating the factors, there also there can be a possible ambiguity, and like that when there is a flaws, it is called unfiltered information. That's all lower at the base of the pyramid. So as a nurse, you are looking for something which is toward the top. It can be A, B, or level 1, level 2, like that. So you can go ahead adopting it if that is applicable. So ethically and in your local factor, it is applicable, you may go ahead doing it. So when it was actually Iowa, there are many models that are guiding the application of evidence-based practice. And Iowa model proposed by Titler et al. So many other models are there. And I thought it is nice if we are able to talk one or two models here. The STAR model, Stevens 2004 was proposed. First and foremost is discovery. Second is summary, then translation, integration, and evaluation. What are these? Discovery stands for what is translation, what is summary, what is integration, evaluation. We'll see. So first and foremost is knowledge discovery. I told you the key component competency is knowledge management. In this era, knowledge is power. If you are powerful, it's because of your knowledge. So first and foremost activity is knowledge discovery. You have to discover what is the gap, and you have to identify the need for it. And then you have to look for the primary research which are dealing with patients who are very similar to whom you are intending to give this and the problem that you are interested in. So such studies you need to discover. Then evidence summary, you need to create evidence, so you need to synthesize it. So you need to so there are 20-30 studies done on it. Say, for example, if you look at the delirium Prevention, you get, if you click and Google, you get 50, 60 articles. You need to select, choose the best one. And you need to synthesize, summarize, and you need to decide on. Next is translation to specific population. You need to prepare an outline and you need to translate those research findings and to your specific population, to your clinical setting. Then integration, then implementation of those evidences through formal and informal method. So you need to say you want to change a practice. It is not easy. We are always no resistant to change. That's why even in the advertisement industry, you might have heard in Tamil Nadu there is one product, grape water, Woodward's grape water. My party gave me. Now, one old granny will say, I gave this to your mother. So you also give to your daughter. Like that, she will say. So we are still having that mindset. So it is not very easy. You need to take the group, you need to educate, you need to convince, and then take the folk along with you. So that is what is the integration. Then once that is rolled out, the process is rolled out, then you need to assess the practice change and the patient outcome, and what is it in terms of patient satisfaction, in terms of the clinical outcome, like cost effectiveness, all that need to be assessed. So that is one model, and in particular to critical care, I found it very useful. This model by Roseworm and Larby, who proposed this model in the year 1999, and you need to assess. Then first is you're assessing the need, and the second is you need to link those deficits or gaps that you identify in your place. You need to link it to the researches you are finding it. Then synthesize, search literature related to major way, critique and weigh evidence, synthesize the best evidence, assess feasibility, benefits and risks. Next is design. You define the proposed change, identify the needed resource, plan implementation process. You have to you need to develop institutional specific bundles, and then you have to pilot test it and evaluate the process and outcome, and decide to adapt, and reject or reject. When it is useful, you decide to adapt and adopt, or you reject it if the implementation is not favorable, outcomes are not favorable. If that is very favorable, then you integrate and you maintain it as a practice. So there are 7 steps to evidence-based practice. First and foremost is a spirit of inquiry to notice internal data that indicates an opportunity to change. Ask questions using Picot questions, then conduct a systematic search, then conduct critical appraisal, implement changes, evaluate, and share results. So the Picot formula alone, I thought I will say, population or patient problem. What is your patient? I stands for intervention, then C stands for comparison and outcome, and T for time. So you have to, in terms of the Picot or SPICE, Picot, so many different evidence-based practice models gives different things. So I thought it is nice if you could familiar. We are much familiar with the bundles that are very common. So in a intensive care unit, invariably most of the patients have different invasive lines. Catheter is one among the one, and always lead to catheter associated urinary tract infection. So it consists of the insertion bundle and maintenance bundle. Perform hand hygiene. This is all known to you. I thought for the novice nurses who have joined us, will be benefiting out of it. So you have to give appropriate training. Many a time, instead of the urethra, identification of urethra, it is mostly in the female instead of inserting it in the urethra, there had been many instances where the catheter is inserted into the vagina, which is full of organism, and you introduce infection from vagina to the urethra. So you need to have a proper training and no handling, and the break in the aseptic technique is always to be so skill-based, competent. You have to ensure that. Then use smallest bore catheter, properly secure the catheter, because the possibility of getting contaminated is very much there. So secure it in the lower abdomen or an anterior thigh, and without giving a large loop. When it is secure but a large loop, again it is getting contaminated. Catheterization as a last measure, not as a first measure. Whenever there is possible, a male patient, condom drain can helpful, you do that. So whenever that is not possible, then only the last resort. Then maintain closed drainage system at all times. Maintain hand hygiene before and after manipulation. Unobstructed urinary flow, very important, because the kinking. So patient lies over it and it gets kinked, and sometimes the drainage bag will touch the floor, or no. You patient mobilize பண்ணும்போது, you just carry the bag above the level of thing. So empty drainage bag without contact certificate. Whenever you are transporting a patient, empty the bag is very, very essential. Routine cleaning of periurethral. Earlier we used to clean the catheter care and urethral using chlorhexidine or povidone, and it is not recommended as per the current CDC guidelines. So the checklist always helps in 100% adherence. So all these bundles, if you have checklist in your setting, it is very helpful. And the VAP prevention bundle, keep the level of the head end at the bed elevated to 30 degree to 45 degree, level 1 evidence. Provide oral care using 2% chlorhexidine, QIH, or as per unit policy level 2, because some studies are not supporting it. That's level 2. Reduce the duration of intubation through early warning protocol using daily sedation occasion and spontaneous breath level 2. The reduced unplanned and re-intubation level 1. Orotracheal tube is much better than nasotracheal tube. Institute gastric prophylaxis, HME filter for humidification. Monitor ET cuff pressure above 20 centimeters to less than 30 centimeters of water. Level 2 evidence. Avoid pooling of secretion with subglottic suctioning port, and provide condensation. You have to drain it, and it should not get inside. So periodically it has to change the circuit whenever visibly soiled or damage. Active surveillance of VAP is level 2 evidence. Then club C, you have different evidences. Subclavian vein is preferred than femoral vein. 1B evidence, 1B level evidence. Avoid using femoral vein. Strong recommendation level 1. Using minimum number of lumens or ports essential. So if one port, single lumen central venous catheter is enough, you use double lumen or triple lumen is not helpful, because the more the number of lumen, the more the chance of club C. Hand hygiene before, after insertion and after handling. Prompt removal of IV catheter, that is when it is no longer essential. Thorough asepsis, skin preparation with antiseptic solution, and chlorhexidine impregnated dressing is recommended 1A. Replace catheter side dressing if visibly wet or loosened. So these are all some of the recommendations you can follow. Like that, you have bundles for SSI. It is very much known to all of you. Hair removal using clippers, saving is not at all recommended. And pre-surgery whole body wash using 4% chlorhexidine. Night, the previous night and the day. Antibiotic prophylaxis 30 to 60 minutes before the starting induction of surgery. Induction of anesthesia. During prolonged surgeries, redosing of antibiotics if the duration exceeds 2 half-life of the antibiotic drug. Intraoperative temperature maintenance above 35.5 degrees centigrade. Patient's temperature, this is meant. So the more the hypothermia, the more chance of infection. So they are recommending this. Preoperative blood glucose level maintenance below the 200 mg. During surgery, movement of personnel in and out of theatre. This is all some of the bundles for prevention of surgical site infection. So now these are all known to you many a times, but what were all some of the newer protocols which was sound interesting to me? I thought I'll give you nurse driven decay protocol, where the nurse is titrating the insulin and IV fluids, and it is found that the mean time is reduced. It is done by Hume et al. In 2019. This is published in Critical Care Medicine Journal. The anion gap closure more than 26%, decrease in mean time to decay resolution, again more than 30%, reduced length of mean ICU stay by 3%. Even 3% means a lot. Then rate of return of decay within 24 hours of discontinuation of insulin decrease by 40%. Lesser incidence of hypoglycemia post resolution of DKA by 33%. Very good result. This is the nurse-driven DKA protocol, and then I have even studied about the computerized titration. So where the nurse need to give the blood glucose level, and the recommended dose will automatically calculate, because there are many a chance, because insulin is a very high drug, high alert, dangerous drug. It has to be very carefully done, dosed, so that computer-based dosing and titration of insulin is also found to be very useful. The nurse-driven sedation analgesia also was found to be very useful. Kaplan et al. Have done a study in 2019 where they have found the nurses, when they are titrating the sedative or analgesic medication in surgical patient in surgical ICU, the protocol group had more ventilated, painless days, low rates of benzodiazepines and opioid usage, 42% versus 84.8% in the conventional care group. More sedation score compared with the targeting in the limits itself. No difference in delirium or length of stay was reported by these researchers. The nurse-driven early progressive mobility protocol. Klein et al. Has done a study where she has tested early progressive mobility protocol, and they have designed a 16-level mobility thing. It used to be, I remember in those days of my BSc, following GI surgery, GJ vagotomy or cholecystectomy, I think 3 days or 4 days they will be bed bound. You can see the drainage tube there, and patient will never move this way, that way, and they will be on nil per oral for so many days, 2-3 days. And this all now with ventilator, now we are thinking of mobilizing in the hallway. So this researchers, Klein and her associates, have designed a 16-step mobility, where the one is bed rest without passive ROM, bed rest with passive ROM, bed rest with active ROM, turn and position every second hour actively, then head of the bed elevated routinely, and head and elevated more than 30-degree, continuous lateral rotation of the legs. Then the level 8 is the head of the bed elevated more than 45 but less than 65 for more than 60 minutes. Then you have head and elevation with the legs in dependent position for more than 30 minutes. Then chair transfer, then dangle with assistance. No, first you will make the patient sit in the bed with dangle with assistance, then stand by at the bed and stand and pivot to chair, then walk with the assistant, walk independently. These are all. But we cannot be so ambitious, and you need to be very careful about progressive. And this is a group collaborative effort. Almost all the activities in an ICU is essentially team-based, and we are now talking about interprofessional education, team building and team function. So this is very, very essential. You need to check for the safety. So this nurse-driven protocol has shown early mobility very beneficial. Walking has increased and sustained at the end of 12 months post implementation of the progressive mobility program, and they have done it in a neuro critically ill patients. Hospital length of stay and psychological distress were reduced compared to the pre-mobility program data at the level of 0.00, p less than 0.001. Then many times, whenever you look into the ICU, you see the alarms. It will be beep 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 beep. It comes. So what is the scenario is like the non-actionable alarm is very high, like 187 alarms per bed per day, and so without even having any sense of it, you silence the alarm. So this is what happens, and to maintain patient safety, never disable alarm. So 2014 Patient Safety Commission has recommended alarm management as a patient safety priority in critical care units. So the continuous alarm, it leads to patient fatigue. Alarm fatigue is a condition that occurs when a user is desensitized by the presence of excessive alarm signals which are non-actionable or false, resulting in delayed or no response. So this is resulting in patient safety problems. So we need to address it. So what is the AACCN alarm management guidelines? Establish interprofessional team to address the alarm issues and develop policies and procedures, provide initial and ongoing education about the device, provide proper skin preparation for ECG electrodes, especially male patients. There won't be any proper skin contact. It will be giving beep 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 alarm because there will be it would have come out of the space. And change the ECG electrodes every day, customize and delay and threshold setting on monitors for O2 saturation, and even all the settings, it need to be customized to patient levels. So for a patient, the blood pressure may be 100 by 60 may be a normal level, or the person may be naturally his pulse rate may be 90 or 100. And if you set at the level of 110, just moving this side, or he coughs out and then that starts giving alarm. So it has to be customized. Nurses need to be taught about it, and there should be a policy for it, because I told you 187 alarms per bed per day. So there are in an ICU, for imagine 10 beds. So unactionable alarms will be, useless alarms will be somewhere 1,870 alarms. So that so you become desensitized to very important alarms where nurses action is immediately recommended. So that is what is the alarm management guidelines. Then this I thought of giving, because many of you must be knowing about it. I thought for novice it will be very useful. Troubleshooting alarms, apnea, what are the cause, no breaths delivered in the set time, inappropriate trigger level, or too poor patient care. So you have to check the arousability and you have to set the mode, probably trigger reset pannano. That is what is the troubleshooting. High pressure alarm, it indicates high airway resistance and reduce high airway resistance and reduce lung compliance could be the reason. Excessive secretions or bronchospasms, kinked tubings, and excessive and patient fighting with the ventilator, atelectasis are all the cause. So you have to clear the airway by appropriate suctioning, bite block, readjust setting by lowering the VT or increasing the respiratory rate. And bronchodilators are also can be recommended. Then low pressure or low minute volume, cuff leak or leak in the circuit, disconnection, inadequate flow. So you have to check, start from the ET tube, whether it is uh, connected properly, check the junctions and connect it properly, and check the cuff pressure. So in VAP also we say cuff pressure should be checked Q12H. So you have to check it whether there is any leak, low pressure, low minute ventilation will be there. Then check ET placement. Sometimes it has gone to one side, then reconnect the ventilator. Then air or O2 alarm, supply pressure is inadequate. Fit the hose correctly to avoid leak at the wall units, and adequate pressure at the central supply stations. So then I thought this is also must be very much interesting for many of you, because many people have walk out of our ICUs. And earlier days, if anybody is in the ventilator, there is no hope, but that now it is ICU. The common scenario is the people walk out of it, but the quality of life is very much poor, and there are a lot of problems the patient post critical care area incident. There are a lot of problems. So the critical care society of critical care medicine in 2018 has recommended ICU liberation bundle. ICU liberation is an evidence-based practice aims to liberate patient from harmful effects of agitation, because the patient is on sedated, ventilated. There are a lot of disturbance. The patient can have delirium, immobility, sleep disturbance. All these are leading to a poor patient quality after post-discharge. So these are some of the bundles that are proposed by the Society of Critical Care Medicine in 2018. The key concept is interprofessional collaboration and communication are essential for effective implementation of ICU liberation bundle to patients. Each ICU liberation bundle, the components are A to F, is a part of a larger bundle. Each element is synergistic with and relies on the others. So you do first bundle, the second or third bundle will also be very helpful, like that. So it is complementary to each other, and it goes well when there is put together. So research shows incremental effect. So improvement is achieved when the patient receive more elements, not just one element. What are the components? The model to implement is engage, educate, execute, and evaluate. This is recommended by SS Society of Critical Care Medicine. The components, A stands for assessment, prevention, and management of pain, because in the ICU, most of the time, it is found that nurses are less competent, providers are less competent in assessing, or there is a negative attitude to assessment because they are not complying. So they are on ventilator. So that has to be regularly assessed, and adequate pain has to be, pain relief should be given. Then B stands for both spontaneous awakening trial and spontaneous breath trial. C stands for choice of analgesia and sedation. D stands for delirium management and prevention. E for early mobility and exercise. F for family engagement and empowerment. So implementation, they recommend preventing pain and optimizing analgesia through pharmacologic and non-pharmacologic therapy, use of validated tools for and nurse-driven titration pathways, and cluster of non-pharmacological intervention is recommended, monitoring pain with age-appropriate tools and situation-appropriate tools. In a non-verbal patients, CPOT scale is more, whenever the patient is able to speak, in verbal pain rating scale will be useful. Critical care pain observation tool is a very valid tool. PPS also is very valid tool. If it is children, there are other valid tools, flock and other things, you can use it. Then implementation of B. The spontaneous awakening trial and spontaneous breath trial had to be tried very much, and the less the number of ventilated hours, the prognosis is good. And so what is that? The coordinated and spontaneous awakening trial followed by breath trial is improving the outcomes. Then implementation of C stands for choice of analgesia. Analgesic sedative is recommended rather than pure sedative. So light sedation is found to be very helpful because the harmful effect of delirium can be avoided. Non-opioid analgesics such as acetaminophen, NSAID, low-dose ketamine, neuropathic drugs like gabapentin, etc. are recommended, but low evidence. Then non-pharmacological therapies in combination as is recommended. So then implementation of delirium prevention is associated with negative outcomes, and in children and adults, increased length of stay in it increases the stay. So it need to be combated effectively. Confusion assessment method for ICU CAM scale and ICDSC scales are there, so that is very useful. And in the bundled approach, recommendations based on this, non-pharmacological strategies should be the first choice. Antipsychotics are not recommended as a routine practice. And delirium, you need to rule out as a precipitating factor, because in elderly, delirium can be because of elderly or in the substance abuse people, the precipitating factor. It's not because of the patient's problem. It is it can happen. So you need to rule out and do assessment for 24 hours and link the bundle to other bundles, and sleep improvement strategies are highly recommended. Then implementation of early mobility and exercise, you have to ensure readiness, multidisciplinary teamwork. I told you already. Something similar to the 16 progressive mobilization is recommended, and employ checklist for assessment of readiness and safety. So passive exercise, active exercise, sitting and bed mobility, then chair transfer, stand, and then walking on the spot and walking. So implementation of F, you need to keep communicating well. That is very essential. And because want of time, I want to rush. Then value is a 5-step mnemonic you can use. I value comments made by the family members, acknowledge family's emotion, listen to their complaints, understanding the patient as a person, elicit family questions. So this is recommended by the ICU for ICU liberation. So I thought I'll just briefly give what is our experience of evidence-based practice at KMCH. KMCH is having a we have 12 ICUs with no exclusively for surgical ICU, medical ICU, trauma ICU, neuro ICU, cardiothoracic ICU, coronary care unit, and so forth. We have 150 beds for ICU, and we have implemented as part of in collaboration with the College of Nursing and the hospital. We had implemented ABCD bundle of delirium prevention, and we have found it very, very useful. Sedation in awakening trial, the interventions given are spontaneous breath trial, coordination, choice of anesthesia, and we have dexmedetomidine is given for, whereas fentanyl and midazolam is given for the conventional historical conventional conventional care group, and the bed mobility we have with it. Then this was found very useful, and you can see subsyndromal delirium was found in all the 100 patients. All the patients, 30 in this group and 30 in that group, both are ventilated mechanically, receive mechanical ventilation, and their stay is the same. So what it was very effective in prevention of delirium, P less than 0.1, it is agitation. The RAS scale is it is reducing agitation. The level of pain score also, CPOT score reduced. So it is very, very useful. Then the choice of analgesia between the experimental and control group was dexmedetomidine, and the other side it is midazolam and fentanyl. And we also have planned unplanned device removal prevention protocol. Here also we have used a protocol approach where the RAS score, based on the RAS score, 0, 1, the patient is calm, -1 to -4, the sedation level is means that the patient is more agitated, and 1 to 4 no, -1 to -4, the sedation, the patient is more sedated, more unresponsive. 1 to 4 agitated, and what are the things we have used wrist mitten and other things, and chemical and verbal also, like frequently communicating. We had a protocol for communication also, then it was found to be very useful, and the device removal was very less. And compared to then in the experimental group, the historical control group, it was 8 device removal, whereas in the experimental group it was 3, where it is a minor. The devices included ET tube and many other devices, chest tube, NG tube, and central venous line, everything. So when you think about, see what is our experiences like, we have also protocolized intra-hospital transfer from one department for majorly patients following surgery or anything. They have to do CT or MRI, and many a time we have found that there are incidents of apnea and arrest and malfunctioning of the ventilators and so forth. So we have prepared a checklist, and that was carried out, and it is integrated into practice in the clinical area in our hospital, where every nurse in the induction period, she gets orientation about the protocol. She is every nurse who's assisting and transferring, and she will check the things, and the checklist is found to be very helpful. So there are many other protocols like oral care protocol for mechanically ventilated patients and so forth. And our experience was very useful and promising. So I hope it will be for you also, but there are a lot of barriers at the institution level, at the individual level. So priorities of the institution varies, limited awareness and inadequate retention and recruitment of the staff, and so many things. In the individual level, resistance to change, inadequate time, lack of ability to identify results, then research orientedness, poor preparation related to research methodology, research utilization, and so forth, and lack of commitment, lack of motivation. These are all, like many a time the study has shown that they prefer, instead of looking into evidence, they prefer to get it from the seniors or by word of mouth. 77% of the nurses want to get instruction regarding how to go about by. 77% only depend on the seniors. So the same thing will be followed by the youngsters. So that is what is the barrier. So we need to create a culture which is scientific and very progressive. So what are the carry home message that I would like to give is evidence-based guidelines is a very powerful tool to provide quality care. Keep pace with the latest evidence to deliver safe and smart care. So Florence Nightingale says, never consider yourself as a finished nurse. Keep learning till the end. This is what is the words of Florence Nightingale. So you need to continue to challenge the practice. So don't have the complacency. Continue to challenge the practice to be evidence-based is my suggestion. And I hope I have given some glimpses of evidence-based practice guidelines in critical care. I'll be very happy to answer your queries if any. And I'm really thankful to Walter Clouvers for giving me this opportunity, and every one of you, the participants who has believed in my ability to give the usefulness for this time that you have given. I am very thankful for your time and patience listening. And thanks once again to everybody, Mrs. Sangeeta, Mr. Raviji, and all the people, and our management, and my colleagues in KMCH, and my students, and the critical care team in our KMCH. And thank you once again. Thanks for Quality is never accident. It is always the result of high intention, sincere effort, intelligent direction, skillful execution. It represents the wise choice of many alternatives. I think it's a befitting quote by William Foster, and so I hope you are going to be more challenging your practice every day and will look for progress every day. Wish you good luck in your nursing career and enjoy nursing and be passionate nurse so that there are many more Florence Nightingales coming up. And critical care area is one where you can make a change in patient's life. I hope you enjoy nursing. God bless you. Thank you so much for all your patient listening. And thanks once again for everybody in organizing this webinar. Thank you.
Thank you very much, Dr. Madhavi. It was such a brilliant presentation, I must say that. You said, ma'am, you'd like to say something here?
I thought I'll just show you these the books that edited by us, and people can make use of it, and the bundles are reference on critical care unit is there. You can refer it, and this handbook gives you it is a very handy and ready reckoner given in a ABCD format, and you can make use of it, and very crisp and beautiful informations are compiled in it. Hope you will use it to become the smart ACE nurses. Thank you once again for everybody.
Thank you very much, ma'am. Thank you very much. Ma'am, we do have some questions, but before we come to the questions part, I would like to invite Dr. Alan Finn, who will talk about the JBI evidence-based practice database of systematic reviews. Alan, I'm just giving you presenting rights to present your sheets.
Hey, if I could share my screen, please. Thank you. So just for a few moments, thank you so much to our presenter for the wonderful presentation. And I wanted to continue the theme of evidence-based practice and to show you some information about JBI, or the Joanna Briggs Institute, and really to follow up and show some information that comes from the company that I work for, which is Ovid, which is a part of Wolters Kluwer. This is the homepage of the Joanna Briggs Institute, and they are an organization which is dedicated to the promotion of evidence-based practice in healthcare, particularly in nursing and allied health. So this is my theme for these few moments. I'm going to show you some information about the JBI EBP, or Evidence-Based Practice Database, on the Ovid platform. And here we can see on the screen the centers which contribute to this database across the world, including in India. We have many collaborative centers in India. So across the world, people are contributing to the JBI materials, and the Joanna Briggs Institute is dedicated to evidence-based practice. They have been a research institute since 1996, and they are based in Adelaide in Australia, which is where I am. It's a not-for-profit organization, and they are dedicated to improving healthcare across all types of health professionals, and they publish many materials, evidence databases, decision support systems, and other tools. Let me take you back here. Definitely, if you're interested, have a look at their website, JBI Global. This is an organization that I would recommend to you. At Ovid, we are an organization of distributing information. So we distribute journals, books, and databases, and many of these are evidence-based. So journals, for example, and books. But today, I am here to show you information in a database. So let me close this, and we'll be taken here. This is the Ovid software, and this is the JBI EBP database. And following our theme of the night, I'm going to look at intensive care as a broad subject area. And inside the database, we will be able to see many full text documents and pieces of research, but two stand out for me as ones that you would definitely want to look at. They are the evidence summaries and the recommended practices. In the page here, we can begin to see the types of publications that come up. Evidence summaries are summaries of research. Recommended practices are practice guidelines. And I know that you've been discussing guidelines during the presentation today. So for each of these items, you are able to see the individual publications at the side of the page here. So if I choose this one as an example, we are able to see that individual publication, and rather than it being 60 pages or 70 pages, it is just 2 pages, and it is a summary of many, many pieces of research that have been done across this subject area. For each of those, there is each of the summaries, there is a reference and a level of evidence indicator. And you will almost certainly know this from other pieces of evidence-based summary information. A level 1 support is a high level of support by the literature. So within the material here, it doesn't just stop at summarizing the content, it makes a recommendation. And that recommendation could begin the process of you taking that research and putting it into practice, because it will be there really to influence the policy that you make within your organization. As another step, though, what we can also look at is the other big part of the content that we find in this database, and these are the recommended practices. So you're able to see here the recommended practices that are associated with this subject, and we're able to look directly to the full text, and you would recognize this as the beginning of a guideline, a summary piece of information really there to provide a succinct direction for a task or something that you are actually going to use to care for a patient. For each of these documents, you can see that these are recently updated and that it gives you an equipment list and then a bulleted or a numbered practice that you see here that follows the steps in actually completing this task in an easy to understand manner. So these items that we see here are ones that are used across the world to standardize practice, and they are frequently updated. You can use it directly, or you can link to it from within your own material to use it as support for your own practice guidelines. So in these few minutes, I hope that I have convinced you perhaps to take a look at the Joanna Briggs or JBI EBP database. It is a part of the suite of content that is provided by Joanna Briggs. They publish journals and also books, but their primary content here is this evidence-based practice database. So can I pass it back to our hosts who will then continue on with your questions for the evening.
Sure, sure. Thank you very much, Alan. Again, so Dr. Madhuri, Dr. Alan, we'll take few questions. Looking to the time that we have today, we'll take few questions only, and also request everybody again, any questions on the databases, the Alan what he has presented, just put it on the Q&A panel. But few questions we'll take for Dr. Madhuri right now. Ma'am, few question is one is that how potassium chloride causes phlebitis. It is phlebitis. Hello.
Hello, can you repeat the question once again?
Sure, ma'am. My question is, ma'am, how potassium chloride causes phlebitis, which is phlebitis?
Phlebitis.
Yeah.
Yeah. Potassium is essentially a intracellular ion, and it stays, most of the amount stays inside the cells, and very less amount, 3.5 to 5 milliequivalents per liter only is there in the extracellular fluid or in the blood. So it is having some corrosive nature. So when it comes, whenever there is a leak in the, probably when potassium chloride is given as for correction of during, whenever a patient gets decay, insulin infusion is given, then at that time insulin potassium is replaced. In some conditions also potassium replacement is necessary where the patient goes for hypokalemia. Hypokalemia as well as hyperkalemia both is endangering to the heart, because very narrow range, if it goes below 3, it again produce very lethal arrhythmias, and when it goes above 5, in case of heart failure or in patients with renal failure, they go for hyperkalemia. That also is very dangerous. So systematically it produced very dangerous effect. So when it is given as an infusion and there is any possibility that there can be leaks, it can cause phlebitis.
Okay, ma'am. Another question is, we'll not take much questions here. Another question is, somebody asking you to please, can you please evaluate the impact of training programs on nurses' information literacy skills for EBP in critical care?
Why EBP? Because it gives a standardized way, because there are a lot of changes happening in the world around, and we also have to go, we have to, everybody want to get the best possible care. As a nurse, it is our mandate. It is not, it's a commitment from us. It's not no, like option to give, whether we can give quality care or safe care. There is no question. So we need to be updated, and patient-based, patient-centered care, quality care is mandated. So we need to update ourselves. Say, for example, just because a person is catheterized, I have seen a patient who had to spend nearly 1 lakh rupee as a cost of care post catheterization. He went in for a imipenem resistant urinary tract infection, where they have to be put him on colistin, and colistin is such a costly medicine which has a lot of side effect. So simple nursing care and regular observation of dependent drainage helps the patient. If you hydrate adequately, it helps. These small things make a lot of difference in critical care. I think we need to be passionate in giving the best possible care, and so evidence-based care is the mandate. And I really want to thank Alan, Mr. Alan Finn, for supplementing a very beautiful content he has shown to us. I think many of the attendees here and to your friends also, you can tell how it is very beautifully it is given. Actually, when I was preparing for this presentation, I was coming through many of the research studies. There were a lot of inconsistencies. How we need to keep up our research mindedness, how there is a need to conduct quality research, and evidence-based practice is a mandate. There is no doubt about it. Thank you.
Thank you, Dr. Madhvi. Thank you so much. I would like to thank all our attendees, our presenter today, to joining this session. And yes, this is the first webinar series we have under Nursing Edge. And yes, in the future, we'll bring out some more such webinars from our leading authors of your favorite books. I would say that. Thank you again for joining us today, and we'll be seeing you very soon with another webinar in Nursing series. Thank you so much.
Thank you. Thank you so much.